Good morning.
Good morning, Linus. How are
Hi,
you?
David. Thank you so much for having me. How are you?
Yeah, we are fine. How are you?
Good, good. Very well. Thank you. Can you see my screen?
No, I can see you, but not your screen.
I am sharing the screen.
Now we can see your screen.
Perfect, perfect. Thank you so much again, Dr. Cantu. It's a pleasure to speak to everyone today on an interesting topic. It's not a topic that we have this in the back of our mind at all the time. It's the impacts of gynecologic cancer treatment on bone health. I have nothing to disclose.
Yeah. Just hold on 1 second.
Okay.
I just want to welcome you and tell everyone that you were with us today. Buenos días a todos, amigos. Estamos aquí con nuestro querido amigo, el doctor Linus Chuang, que es profesor y jefe del Departamento de Ginecología y Obstetricia de Novant Health en la universidad, además de la Universidad de Vermont School of Medicine. Él es gineco-oncólogo, es parte de asuntos internacionales de ASCO y como les comentábamos, queremos ver el impacto de los tratamientos gineco-oncológicos en la salud ósea. Y como muy bien decía Linus, este es un tema que usualmente no tocamos, pero que es de suma importancia, sobre todo en países como los nuestros, donde el cáncer cervicuterino tiene una alta prevalencia y aquellas pacientes que son tratadas con quimio-radioterapia concomitante y que son jóvenes tienen pues una menopausia a edades más tempranas, lo cual impacta en su calidad ósea, además del resto de su calidad de vida. Lo mismo ocurre con las pacientes con cáncer de ovario, que les hacemos cirugías estadificadoras, y cáncer de endometrio, donde preservamos las gónadas. Asimismo, las pacientes con cáncer de mama que son tratadas de manera radical y que requieren su presión ovárica, pues tienen un impacto importante. Y de ahí que nos preocupó este tema y consideramos a Linus como una excelente alternativa para este tema. Linus, please continue with your presentation. I would like to thank you for accepting this invitation and for your participation today.
Thank you so much for your kind words. As always, I owe it to you a lot, and thank you. This is a really great honor and a privilege to speak in front of all of you on a very important topic. It's not something that we always think about, but it's something we really should. I have nothing to disclose in relationship to this topic. And as everyone knows, breast cancer, along with other gynecologic cancer, is the leading cause of death in women. And unfortunately, 10% of the new cases of breast cancer are diagnosed in women of reproductive age when they are really looking at keeping the ovarian function and also have opportunity to conceive and have childbearing. So it's a critical time for women when they develop breast and gynecologic cancer before menopause, and especially when they are still actively considering childbearing. So it's a major challenge for the patients and ourselves when these young women are facing with this new diagnosis. And as you all know, breast cancer is the most common cancer in women. And during the course of the treatment of breast cancer, hormonal therapy, which has effects on bone health, are frequently used. And bone metastasis is known to occur in breast cancers, although it's not as common in gynecologic cancers. But cervical, ovarian, uterine cancers are often seen in women at younger age, before menopause, and when the management of that can affect the ovarian function, lead to menopause and affecting the bone health. So it's really critical to address when cancer happens in young women at a time where hormonal supports are important, especially for the bone health, is what we need to consider, what we should to do for these women. So menopause is a state that of course all the periods stop, but it's a state that loss of ovarian follicular activity leads to a significant fall in the circulating estrogen, so it's a drop. It's worse more in younger women when they have to undergo surgery or undergo treatment and lead to a loss of the ovarian function. A so-called surgical menopause, it's often a lot harder than the natural menopause. And the most rapid bone loss happens in the first 3 years after menopause, with on the average 2 to 5% loss per year for the first 3 years. And after the first 3 years, the loss slows down to about 0.5 to 1% per year. The loss of a bone most is in the trabecular bone, like the spine, then the cortical bones, like the hip. So it's this menopause occurs. Once it occurs, the effects on the bone, it's most critical in the first 3 years. So something that when we need to address it, we should address it really quickly, and not to say wait a few years. When the critical time of the first 3 years, it's already lost. And the effect on the bone are mostly on the spine than the hip bones. So we should always be considering menopause as an effect from our cancer treatment. But what about the treatment itself leading to the bone loss, or so-called the cancer treatment-induced bone loss, or CTIBL, should be one thing that we should all think about, to consider about. And the management of these treatment-induced bone loss, we should follow the guidelines in management of these patients, and we should offer baseline and periodic follow-up evaluations of our patients that may suffer from bone loss because of her cancer treatments. And this can be prevented by several options, by the agents that can help with the bone, or so-called bone targeting agents. Obviously, it's very important, the calcium and vitamin D supplementations. One thing that many of us may forget is the modification of lifestyles may also help in preserving the bone and minimizing the bone loss. So there are several sex steroids which is critical for the bone health. Up and foremost are the androgens and estrogens. These two hormones maintain the bone growth and maturation, and it keeps the bone maintain its integrity. So these hormones plays a vital role. Other less important or less significant hormones includes activins and inhibins. So these hormones are really critical for bone health. And in how do they play that role is estrogen basically help us to decrease the reabsorption of bone, and its effect it's exerted through the estrogen receptor alpha and beta. Basically, these receptors are expressed by osteoblasts, the one that grow bones, and osteoclasts that break down bones. And with the estrogen, it can increase the bone formation or the osteoblast number and activities. And in turn, it suppresses the maturation of osteoclast precursors. And by suppressing the osteoclast precursors, it causes the apoptosis of osteoclast. So you have osteoblasts generate bone cells, prevent the bone reabsorptions by causing the osteoclast apoptosis. So when a woman loses her ovary and leads to menopause with estrogen deficiency, it can increase the rate of osteocyte apoptosis and leading to bone loss. And how about androgen? Androgen, it has a little bit circulating androgens in women, and they are predominantly produced by adrenal gland and ovaries. As you are all very familiar with, these estrogens are the DHEAS, DHEA, androstenedione, testosterone, dihydrotestosterone. These are important androgens, and the female testosterone usually is produced through the peripheral aromatization of androstenedione. So this is something that can be produced by conversions. And with androgen, it helps women and men to promote the plate chondrocytes and promote the longitudinal bone growth. So both estrogen and androgen plays a vital role in the bone health. Now, what about activins and inhibins? They are part of TGF-beta superfamily, and they exert their effect by interacting with the type 2 serine threonine kinase receptors. And what does inhibin A and B do? They suppresses gonadotropin secretion from the pituitary gland, and the inhibin B levels drops slowly after woman ages. And so what it does is suppress gonadotropin, and in turn leading to reduction in the production of hormones. And so there is bone loss in patients with breast cancer primarily come from either the chemotherapy or the hormonal therapies that they receive. And it has different mechanisms, and two different chemotherapy which commonly used in breast cancer treatment, the cyclophosphamide and doxorubicin. And they both can induce menopause. And cyclophosphamide damages mostly granulosa cells and oocytes and affects the osteoclast and osteoblast precursors. And the doxorubicin, they're more of gonadotoxic and lead to premature ovarian failure. And so they come through the different mechanisms. And here is a study from Cameron back in 2010, looking at the decline over time in our bones. As you can see here, the spines are affected more than the hip. So the first 6 months, and almost all patients after they have amenorrhea, they develop bone loss. And the bone loss is usually on the lumbar spine. They experience this bone mass density decrease. And this decrease is really independent of age, ovarian function, type of chemotherapy. But once amenorrhea happens, the bone loss begins. And usually more again on the lumbar spines. And the following 6 months, and it continued to decrease, but more so in women experiencing amenorrhea, or they continue to have low estradiol levels. So again, the Cameron study looking at different chemotherapy agents. You see in the regimens, different regimens, 6 months afterwards, and 12 months afterwards. They all show consistent decline. It doesn't matter which combination of drugs, it can have effect on the bone marrow density. When the treatment is supplemented with calcium and vitamin D, it really can help in these changes in the bone marrow density. And by giving the supplementation, it does help with slowing down these decreases in changes in the bone marrow densities. So it's really helpful to remember and consider calcium vitamin D treatments. So in summary, for chemotherapy-induced bone loss is really currently looked at as more of a consequence of premature ovarian failure rather than the result of a direct bone damage. In other words, that ovary plays a vital role, and it is really not the drug itself that affects them, but the drugs affects the ovary, leading to menopause and subsequently damages on the bone, leading to bone loss. So here is a diagram looking at drugs that are going to toxic chemotherapy can affect the primordial follicles in the production of FSH or LH level, and it leads to apoptosis and reduction of ovarian reserve, and affecting the early menopause, infertility, increased FSH, low AMH, and low the follicle counts. So the gonadotoxic chemotherapy primarily not affecting the bone itself, but primarily affecting the ovaries through that pathway. And what about hormones that women receive for their breast cancer treatment? Either GnRH and tamoxifen here on the study published in 2008, looking at this anastrozole alone has the greatest bone loss versus tamoxifen alone. But if you treat them with zoledronate, and you can prevent this loss. So the combination of anastrozole with zoledronate, see in this, there is really over time not significant of a bone loss. The same with tamoxifen and zoledronate. So the management can be using these agents to prevent further bone loss as a result of the hormonal therapy. So I just want to show you pay your attention on looking at the AI treatment with the denosumab comparing to placebo. The bone fracture rate is significantly lower with the supplementation of these agents. So current guideline for the bone health assessment, the recommendation or the guideline from ESMO and NCCN recommends looking at bone health assessment in women with iatrogenic, premature ovarian failure, the shutdown of ovary because the treatments, and in patients treated with AIs for breast cancers. And we should have a baseline evaluation, taking a good history to identify the risk factor for the fragility fractures. And bone density assessment is recommended baseline and should be repeated periodically. For me, it's every 2-3 years on these women. So there is actually a calculation tool here for you to put in, looking at patient's age, sex, weight, height, whether there is a previous fracture or not, and whether there is a fracture in the hip, in the parents' current smoking history, use of glucocorticoid steroids, whether there's a history of rheumatoid arthritis, whether there's a secondary osteoporosis, drink alcohol 3 or more units per day, femoral neck bone marrow densities. So this can help us to calculate the risk of 10-year probability of fracture with a bone marrow density. And this is also available internationally. There's a version in Spanish, and here's so it's really helpful to use on this tool to calculate the fracture risk. Unfortunately, this fracture tool is really helpful, but it did not really include cancer treatment as a risk factor. And so it's important that we use a tool, but it's not like entirely helpful for us because what we are treating for our patients, it is not included in this formula. So it's the other thing that can be helpful for us is looking at the level of calcium, phosphate, vitamin D, parathyroid hormone, and the kidney function through the creatinine clearance. So we can use a combination of the tool and also the laboratory testing to predict. But still, we have to take into account what kind of cancer therapies a patient has. Like we talked about earlier, the chemotherapy drugs, the hormonal drugs, they also exert some effects on the bone and affecting the bone health, bone densities. So the management of this cancer treatment-induced bone loss also includes that we talk about. It's very important to advise our patient to have lifestyle changes, including reduction or stopping the use of alcohol and stopping this cigarette smoking cessations are very important. And I often talk to my patients that smoking is just burn up your estrogen faster, make you get older, make your bone get weaker, and trying to get them to be impressed and wanting to stop smoking so they can hopefully maintain the youth. And smoking is something really is very important to stopping the bone fractures, prevent resorption of bones, and exercise is very important. Weight-bearing exercise is important to prevent the bone loss. And something really important for most of our men and women is to start taking calcium, vitamin D, and the supplementations. It's important to remember to be 1,000 milligram per day, along with vitamin D supplementations, also about 1,000 international units per day. Now, using the bisphosphonate in patients who had already experienced bone loss, it's important. And there are many trials looking at the use of bisphosphonate in patients, as you can see here with the studies comparing the experimental arms and control arms by studying upfront zoledronate and comparing the delay treatments. And basically, by starting upfront, you have better bone mass density comparing to those that did not have in the lumbar spines. And many studies confirm the upfront starting the bisphosphonate in these hormonal therapies. So what are the guidance for the use of bone targeting agents in breast cancer? It's if a woman has risk factors for fracture and the baseline T-score is less than minus 1.5, we should consider starting these bone targeting agents. If the T-score is greater than -2, and they really should be started, especially during the first year of AI treatments. There's no consensus in terms of how long should we be continuing on these agents, but most of the time people will go by what is recommended by Clinical Care of Ontario from Canada and ASCO recommendations for the zoledronate not more than 5 years and crodronate not more than 3 years. And many patients, they are started, they're not adherent to the treatment. I think it's important to make sure they take the medication as recommended for premenopausal women, and 4 milligram of zoledronate every 6 months is recommended in addition to calcium and vitamin D. And postmenopausal women, both oral and intravenous, have been shown to be effective in preventing the bone loss. The bone targeting agents are generally very well tolerated, and the intravenous biphosphonate, like zoledronate, and the side effect may be just a short period of time of bone pain, pain in the joints, and muscle pain, fever, and nausea. The oral one may have the concern of esophagitis and other GI disorders. I think one concern most people have is the necrosis of the jaws. And it's really rare. Most studies show that it's about 1.3%, and mostly women or men that already had the bone mets, they're more likely to happen for the osteonecrosis. So what are the other options for women with breast cancer? I think one thing that can be think about is the ovarian tissue cryopreservation and transplantation. My good friend, Dr. Oktay from here, initially from Turkey, was really the first to pioneer this technique by preserving some ovarian tissues. So I've sent my patients to him. He would do a laparoscopic retrieval of ovarian tissues, and it's pretty good, although it's considered experimental, but it's widely practiced for women to retrieve some of our ovarian tissues. I think the key point here in terms of breast cancer is we are seeing improved survivals among patients we are treating. And so it's really important to pay attention on the survivorship, especially some of our long-term consequences of cancer treatments, and bone health being one of them. The risk of osteoporosis and fracture and can be avoided by lifestyle changes and the use of bisphosphonates like zoledronate, denosumab, are the most commonly studied agents. And there is a need to improve the awareness of these cancer treatment-induced bone loss, either through the agent itself or the menopause that induce bone loss. And it's really important for us to be aware of it. Now I want to turn our attention to gynecologic cancers. We know that cervical cancer often diagnosed in reproductive age women. As a matter of fact, the studies show about 45% of cases can happen, depends on where you are, women younger than 45 years old. So it is important to talk about fertility issues. It's also talking about hormonal issues because many of these treatments can lead to the loss of ovarian function and lead to menopause and subsequently affecting our bone. So options for cervical cancer management is really looking at by preserving the ovarian function. And one way that we often do, of course, you can do a transplantation, is transposition of ovaries. It's one techniques that we can do. So it really depends on the study you read it. You read, and some said it's 50%. And there was one recent series looking at properly done, it really can preserve 60% of ovarian functions. Now, I think it's really critical. The success also depends on how good the ovary is in addition to your techniques. So if someone has a good ovarian function, say if you look at a woman that is in their 30s with good ovarian function, the preservation by ovarian transposition will be good. But if you look at a woman that is older, 40 years old or 45, and then they don't have a good ovarian function, then of course the success would not be as good in the ovarian transpositions. And what is considered to be good normal ovarian function is you have low FSH, you have good estradiol level, and you can see follicles on the ultrasound. So these are the women that may be a good candidate for ovarian transposition, as opposed to those that already don't have a good function to start with. By doing a transposition, may strangulate the blood flow and leading to ovarian failure. So the success rate tend to be higher with younger women, but overall I would say 50-60% to be successful. And I think the very important is really where you put the ovary at when you transpose the ovary. There's some key points that I keep in mind all the time is I have to really want to have a 4 centimeter distance away from the transposed ovary to the radiation field, because we always worry about the scatter radiation affecting the transposed ovary. And also keep in mind to have an optimum cutoff distance of 1.5 centimeter above the iliac crest. And that will be generally away from the radiation field. And you really should avoid compromising the blood supply of the ovary by overstretching, torsion, kinking of the infundibulopelvic pelvic ligament. And here is a picture of how you look. It looks pink, looks good. It attached really well and not affecting the blood supply. And it's really important how you do this is critical. And then the next I want to talk about in what kind of patient with endometrial cancer that we can consider preserving the ovaries. And it's not often to see a patient develop endometrial cancer in a younger age group. Younger than 40, it's only about 45%. Premenopausally, it's about, David, it's about 10-20%. It's not often. And so premenopausal women, if we have a patient that is low risk endometrial cancer, can we look at progestin therapy and deferral of surgical staging? I think most of the time we think about this is women who still want to preserve fertility, not so much because we want to preserve the ovary and do the progestin and deferral of surgical staging. I would say the younger women, for those younger women that had completed childbearing, I would consider hysterectomy. If they have a low-risk endometrial cancer, I would consider preserving the ovary. So if you have a patient with a grade 1 endometrial cancer, she's 35 years old, and you look at the grade and the depth, and maybe you can do it preoperative with imagings. If you have a patient that is 35 years old, grade 1, she already has 3 children, so I would think doing a hysterectomy is very reasonable rather than progestin or IUD therapies. So the big question about these women is should we be concerned about Lynch syndrome or not? And if we know that someone does not have Lynch syndrome and the problem with spreading to the ovary, developing cancer later because of Lynch, it should be low, 5%. And so at my institution here, our DNC specimen, the curettage specimen, we're able to use MMR gene testing to screen for Lynch. So if I have a patient 35 years old, based on the curettage specimen, the MMR gene testing show no loss of the proteins, and I feel good about it. This patient does not likely have Lynch syndrome, so I can look at preserving the ovary. Of course, there's also a concern about synchronous endometrioid adenocarcinoma of uterus with the ovarian endometrioid cancer. It can happen. That incidence may be 25%, but if I look at the ovary grossly normal, and of course I counsel my patients, I think the incidence the risk should be small. But do we have any studies to support us that it is safe not removing the ovary in women? Is it safe? Is it going to affect the survivals? So there was retrospective studies, and there was a study done in 2013 looking at the meta-analysis of keeping the ovary in patients with low-risk endometrial cancer, and they found no effect on overall survival. My friend Jason Wright from Columbia, he did a lot of our data analysis. So he looked at a national cancer database, and women younger than 50 years old, 15,000 women, that many, and among them 7% had ovarian preservation. And what he found was it was not independently associated with survival. In other words, saving the ovary did not affect their survival. And so it is really based on a retrospective study. It seems to be safe in young women who want to preserve their ovary, especially in women that have low-risk endometrial cancer, one can consider. And I think there is a clinical trial now looking at the study. Someone with stage 1A, grade 1, you think it's going to have, there's no loss of MMR proteins to keep their ovary, and then follow up on these patients. Despite that, we all know that it could potentially be safe, but as we all know, most of these young women, unfortunately, still undergoing oophorectomy. So maybe this is something we need to change in women that carefully selected low risk could consider preserving the ovary, because ovarian function is really vital in many women's. Now, what about ovarian cancer? Can we preserve ovarian cancer? I think all of you know that it is really possible for women in reproductive age group to consider preserving the ovary in stage 1A epithelial ovarian cancers. It is considered safe. To do that, of course, that is to say we have a BRCA testing. It is negative to continue to save these ovaries for women when they develop ovarian cancer at a younger age. Now, germ cell tumor, we are all very familiar with. Despite the need of chemotherapy, many of them will resume normal functions after chemotherapy. We know by giving chemotherapy, even though they have transient menopause with the chemotherapy, they have no increased risk in pregnancy outcomes. I think among all these germ cell tumor that affect the other ovary, more likely to affect would be dysgerminoma, have a greater risk, but it's still, the risk is small. And so a lot of time people have this question about, what about biopsying the contralateral ovary, just to make sure it is not affecting the other ovary? It is not recommended at this time. If it looks normal, you don't really need to do a biopsy. You shouldn't do a biopsy, because by biopsying, then you might affect the ovarian function, leading to adhesions. Ovarian sex cord stromal tumors, and they have really great cure rate. Most of these tumors are stage 1. I think we really need to consider preserving the contralateral ovary if it is normal. As you can see on this diagram here, that this is a birth. The ovarian follicle, we have a lot of them are prior to birth and go up to 6 million. But once after birth, and especially pre-menarche, it has really a sudden drop, significant drop. And once you reach 20, it's really becoming stable at a level that is really low. So most of damages to the ovary, there's more from radiation than chemotherapy, and the radiation damages are dose and age dependent because of this. If you give radiation at an earlier age, the damage is not as much. They may experience just transient amenorrhea. But for women after 40 years old, if you just give for 6th grade or 600 rats, it causes permanent damage. And this happens really quickly, right? 600 rats, just really a few days of radiation is gone. So ovarian suppression using the toxicity from chemotherapy may benefit from GnRH contraceptives, and they may be beneficial for protection menstrual functions. But to date, there's no evidence to show that GnRH agonists and the co-treatment improves the rate of spontaneous pregnancy after chemotherapy. It might preserve the menstrual function, but not the pregnancy. So what are the options for ovarian preservations? As a surgeon, what we think about is transpositions, whether we can just preserve one ovary, not removing the other. Now, for trachelectomy, this is for cervical cancer, and I think this is just very early cervical cancer. It's not really listed here, but ovarian decortication, ovarian tissue cryopreservations, autotransplantation. I don't know whether you're doing in Mexico City, so this could be a way to preserve some ovarian tissues, especially non-gynecologic cancers. So chemotherapeutic drugs usually affects dividing cells, like granulosa and thicker cells, and it decreases the number of large maturing follicles. So under 40 years old, they develop amenorrhea during chemotherapy. They often resumes after stopping the chemotherapy, and fertility may also even return. So among the chemotherapy drugs that we use, which has causes most damages, what is most well known are the cyclophosphamide and melphalan, and they definitely show significant damage in the ovarian functions. Limbrastin, cisplatin, VP6, imatinib, probable damages, and methotrexate, 5-FU, mitomycin is really low effects, and doxorubicin, daunorubicin, bleomycin unknown. So when choosing the agents, especially now for ovarian cancer treatments, we like to avoid using the cyclophosphamide, which is not it's used today that often anyway. Multi-drugs, by combining several agents, are often done in early stage breast cancer, CMF, and anthracycline base, and CMF has a greater risk, although most of them have effects on the ovaries and lead to bone density loss. The biochemical markers which often use the AMH inhibins and FSH to know what is our ovarian reserve. So in conclusion, the primary harm to bone health is more of a result of menopause, and secondary effects can be from drugs, radiation, chemotherapy, surgery. And so attention should be made to preserve, hopefully, the ovaries and its effects on the ovary by radiation and drugs and chemotherapy. I think personal well-being is important. Calcium, vitamin D, exercise, avoids using alcohol, tobacco, smokings. And of course, we can supplement with bone targeting agents to preserve the bones. So in closing, it is important to remember our job as oncologists is to improve the quality of life, not just delaying death. So I want to thank you, Dr. Ken Chu, for his kind invitation, for this opportunity to speak to you on a very important topic on the survivorship on our patients. So thank you so much for listening to me, and I'd like to take some questions from you if you have any. Thank you, David. Thanks so much.
Thank you, Dr. Chuang. It was very interesting, and as you said, as you mentioned before, we don't have this in the top of our mind, but it is important to consider these issues during the treatment and the follow-up of our patients. Now we have the question and answer session, and we have for that Professor Salim Barquet, who is in charge of our young patient clinic here at the National Cancer Institute, and he's going to coordinate the question and answer session. Salim?
Yes. Good morning, Dr. Chuang. It was a very interesting masterclass about bone health. And we have several questions about this bone health. It's like we have two different kind of patients. We have the young patients who has the premature ovarian failure because the treatment, and also we have the postmenopausic women who they already has some bone loss. So when should we start to have the medical treatment for each of these groups? When they are in the oncologic treatment, or first we have to do like evaluation, and after that we should treat them? What is your opinion about when to start to treat these patients?
Thank you so much. Those are very important questions. I think the really important point is to start early, think early, because we know all these treatments will lead to some impact on the ovary and bone. So it is, I think we have to look at what kind of treatments, how long the treatment will be, but there's no doubt it will be, there are some impact. So the key point I take away from reviewing this is really think about it and do a baseline evaluations, looking at if anything that needs to be treated is to do it early on. I think we can start on doing baseline evaluations by looking at the bone mass density and on the patient that it's going to start undergoing treatment, and to monitor them throughout the course. And I think through the calculation is helpful when to start treatments, but also we have to take into consideration what kind of treatments and the other factors, other assessments that can help us with factoring in. So I think it's really important baseline evaluation followed by the calculation of this, and it's careful history, and to look at fragility fractures, the risk factors, identify them, and then assessment a baseline, and should be repeated periodically. And I think this calculation tool is helpful. I think one should start thinking a lot earlier if the calculation indicating the risk is higher. And we have to take into consideration of what are the calcium level, the phosphonate. So it is important to start early, think early, to monitoring continuously. The loss is most significant in the very beginning, as you know, it's the first 3 years. So it is really critical, the first 3 years, 2 to 5% loss per year. And when you have this bone loss, and so I think early on start thinking to supplement them, calcium, vitamin D, exercise, stop smoking, cut down drinking, and exercise is so important, monitoring them, and then to continue the bone loss monitor. If they experiencing, or by calculations, high, to start treatment early, and and that will really help. You see this study here, by early on, denosumab and and early, there was one study looking at what the difference of upfront versus delay makes such a big impact on the starting on AI treatments. And early on, it can prevent the bone loss and lumbar spine. The variation is so drastic. So that was a very good question. So think about it all the time, baseline, encouraging lifestyle changes. And if you are going to start letrozole for a long time, just may as well you have a risk already, start early. And it really can prevent this bone loss.
Okay. Another question is, what is your opinion about the use of denosumab instead zoledronic acid?
I have more experience with zoledronic acid. It's just because the time of injections, I don't have special preference on one over the other, but I'm more comfortable with that. How's your practice in NCI? What is your preference in treatments?
Here, we have more experience in zoledronic acid.
The same with us here. I agree with you. It's something that I use it more often.
But I think that, for example, some of the oncologists, the medical oncologists,
Mm-hmm.
they used to use more the
denosumab.
Yeah.
Yeah, I think it's a preference. I really don't know. As you can see this, yeah, I don't know the. They all show the effects on preservation or decrease in bone fracture in the study here.
And for the time, you recommend just the 5 years for the zoledronic acid, and then use another medical treatment, or just the follow-up of the bone health?
I'm worried about long-term use, and I look at the guideline from ASCO. It's really no more than 5 years. I think the side effects what worry my patient the most. And if I can preserve the bone early on, and I'm happy about that because early treatment is the key. And when it's stabilized, I would stop zoledronic but maintain my calcium, vitamin D's, other treatments. So I would not go beyond that. I'm just worried about the other risk of taking a long-term zoledronic.
Okay. So you might consider to use the zoledronate for 5 years, plus the calcium and vitamin D, and after that, just calcium and vitamin D and the bone density measurements, right?
Correct, David. I agree with you. Yeah, that's what my practice is.
And what about your opinion about the estrogen therapy in young women?
Absolutely. So yesterday I had a patient who had hysterectomy, and she's 52 years old, and she had grade 3 endometrial cancer, but it turned out to be stage 1A, grade 3, got her brachytherapy, and she experienced a lot of hot flushes, mood swings. So I went through with her about the various managements on the menopausal symptoms. And she's to the point every 2 hours she sweats. And here the weather is starting to be cold, but she doesn't want to turn on the heat. Like Mexico City, it's cold, but you don't want to turn on the heat. You can use the heat, but the husband is not happy. She's sweating. So went through the list. There is really, we have studies to show that it is retrospective to show that it's safe in someone with low risk patients. And there's one GOG study really never finished by Rich Barakat looking at the safety of estrogen use. And so estrogen use should be safe, in women, either with that low-risk endometrial cancer after surgery or with patients that have BRCA mutations, having the ovary removed. It really should be safe. I mean, there's other options to do, like Relisons, which is a product from Sweden, or other medications that can, but estrogen use should be really safe in selected women. So I advised her, and we're going to start for using a short period of time just to help the patients. So estrogen use both for symptom and bone preservation is something to consider in women after menopause.
Okay. Another question is, what is your opinion about the ovarian transplant or auto-transplant? Is it effective for the symptoms and also for the bone preservations, or just for the symptoms, and these patients should use another medical treatment?
Right. So I actually worked with Kudlak Oktay before, and you know him. He's the first person. He was from Turkey, and I had done surgery with him and do a laparoscopy, remove part of the ovary, and to be put it under the skin or in the freezer to preserve. So if you put it in the freezer, obviously you're not going to have estrogens, and these were being either used as infertility therapy or hormonal therapies, and that if it is placed under the skin. So many of this, it's not really used in the gynecologic situations. I just sent him a patient with 35 years old with 7 centimeter left ovarian tumor, 14 centimeter right ovarian tumor. And we're hoping to hopefully this is just a borderline tumor and not cancer. It's really difficult to use it when it's ovarian cancer and preserve part of the ovary. So a lot of his patients are not gynecologic cancers, undergoing radiation, chemotherapy, lymphoma, breast cancers, preserving part of the ovary, just would like to have fertility considerations. I don't think I know enough. I don't think it's still considered standard of care. Do you do that in Mexico?
No, we don't.
Right. No. Dr. Oktay often speaks on it. He does it, and I have patients and has some value in that, but I don't think it's considered as a standard of care. It's
there are some reports here in Mexico from some gynecologists that they think that it's a good options for the menopause symptoms, but the concerns it's about that it doesn't last too long, this hormone or this transplant, because they start with the symptoms again after 3 years or 2 years after the transplant.
Right.
Would you consider these transplantations in GYN tumors? Because my concern would be if that piece of ovary has some malignant cells, what would happen if they grow somewhere else and have a soft tissue metastasis or something like that?
No, I agree with you. So this month, fertility and sterility has a big study came up from Scandinavian, I think Sweden, on borderline tumors. So my patients that I have been considering is borderline may be an option. So I have 2 patients actually, a borderline removed on one ovary and now come back on the other ovary. They're all very young. So could I preserve some ovary? But I have to say today, the option of oocyte, freezing of oocyte preservation is that they can still preserve their fertility, but not so much for hormonal preservations. And I think there might be a role for for borderline tumor can be preserving, I would be really concerned about the ovarian cancer, like David, like you suggested, and I would be really worried about that, knowing that's ovarian cancer, and but I actually just sent that 14 and 7 centimeter patient to see Dr. Octay, and I'd be happy to connect you, David, with Dr. Octay for talks. He's really amazing.
Would be fantastic.
Yeah, so I would go connect you with him, and he's really great in speaking on the topic.
And what would you think about these biosimilar hormones and these pellets as hormone replacement therapy in this group of patients?
Yeah, so it is not it is biosimilar. It is something that could be considered, but low on my list. I have a lot of patients want biosimilars, even Brad cohorts. They want it, but it is not what I be on my list today. When I look at biosimilar, a lot of them I look at the cost of that, but I would say I would start with my standard of care management, go to my biosimilar, then go to natural stuff. And are you using it, biosimilars, for your patients on?
No.
Yeah, I don't think we are using it. It's down lower on my list, and some patients are just so worried about using zorizonate, especially with osteonecrosis. No matter how I reassure them, the risk is very small, but they're still very worried. And but
okay.
Thank you so much, David. I have to go.
Yes. Actually, we are going to finish now. We want to thank you for your kind acceptance of participating with us. It was a great talk, and we had more than 60 people connected, which is fantastic. It was a multidisciplinary session. We had pathologists, we had people from Central America, we have GYN oncologists, of course, we have surgical oncologists, medical oncologists, we have many disciplines together today. And we thank you, Linus. Muchísimas gracias a todos. Nos vemos aquí muy pronto. Gracias, Salim. Gracias, Linus. Thank you, Linus. See you later.
Thank you.
Stay
David.
safe. Stay safe.
Have a good day.
Bye.
Bye-bye.